talk about distal radius fractures. And basically an overview of, what I'll talk about briefly, kind of go over the anatomy, a little on the incidence and presentation that you may see in the ER. We'll go over some radiographs and then fracture classifications, some of the eponyms, and then treatment guidelines as we have them now. And then we'll go through some case-specific examples. And Neil and Zach, I'll probably have you guys just read a few x-rays for us and give us your thoughts later in the presentation here. So the anatomy, the distal radius articulates with the carpus and serves as the origin of the volar and dorsal ligaments of the wrist to help stabilize the carpus. There are basically three articular surfaces to the distal radius. There's the scaphoid fossa, which articulates with the scaphoid, the lunate fossa, which articulates with the lunate, and then the sigmoid notch, which makes up a component of the DRUJ and articulates with the ulnar head distally there. So you guys can see that here. And then basically there's three columns that we'll talk about in regards to distal radius fractures. So the radial column, we'll talk about the radial styloid and scaphoid fossa when we're referencing the radial column, the intermediate column, which is the lunate fossa and sigmoid notch, and then the ulnar column, which includes the TFCC and the distal ulna as well. So presentation, the epidemiology of it, it's the most common fracture seen in the emergency department. It's about 640,000 annually with a bimodal distribution. So typically young men, higher energy traumas, and then, older people, ground level falls once they kind of get osteoporotic. And it does represent a fragility fracture in that population. So it's important to evaluate for osteoporosis, make sure, their vitamin D levels are optimized, and see if they need other treatment. The mechanism, typically it's a fall on an outstretched hand, particularly in the elderly population. In the younger population, it can be the result of a higher energy trauma as well. So your polytraumas, make sure you're always kind of palpating and feeling for that. On exam, you definitely want to evaluate for open injuries. The distal ulna has a tendency to make a little poke hole sometimes, and it's important to note that. You want to evaluate their neurovascular status, so make sure all the nerves crossing the wrist are working okay. And then you want to rule out acute carpal tunnel syndrome. So that can occur in 5.4 to 8.6% of cases. And basically, if it's worse or there's no improvement after a closed reduction, then that's your indication to perform an urgent or emergent carpal tunnel release, depending on their situation. So we have had that a few times this year. I know Neil's seen one with me. But yeah, that can be something that's definitely going on, so make sure you evaluate for that. So radiographs are average radiologic parameters. Radial inclination is about 23 degrees, volar tilt about 11 degrees, and radial height is about 13. So the inclination is basically measured from the tip of the radial styloid to the sort of most ulnar articular part of the lunate fossa. And then that's drawn to a line perpendicular to the long axis of the radius, and that should be about 23 degrees. That parameter can obviously change, and that's one of the things we're kind of looking for when we're assessing reductions and quality of reduction. The radial height is measured in a similar fashion, but it's just that distance. So basically, tip of the styloid down to the ulnarmost part of the lunate fossa. And that height should be about 13 millimeters. And then your volar tilt is measured on your lateral view, and that's basically from the dorsal rim to the volar rim against a line perpendicular to the long axis of the radius, and that should be about 11. I thought it'd be a good idea to talk through, what makes a good wrist x-ray, because that's something we don't ever really talk through, but it's something I think that's important, especially when you're trying to evaluate, these numbers, which can change, with the quality of your x-ray. So the PA radiograph ideally is obtained with the shoulder abducted 90 from the trunk and the elbow flexed 90 degrees and the forearm in a pronated to neutral position. So sort of as is seen in this photo. And the reason we do that is because your ulnar variance does change slightly with pronation and supination of the arm. So if you have them kind of adducted to their side and supinated over or pronated over, that'll affect the relative length of the ulna, because it's actually the radius that's moving in this case. So the radius will appear, shorter or longer depending on their pronation or supination of their arm. The beam should be centered on the carpus and should include, the base of the metacarpals, the entire carpus, and then your distal radius and ulna. On a good PA radiograph, you should be able to see the ECU groove, which you can in this radiograph down here. So you should be able to see that structure as it comes across, and it should be just kind of radial or at the ulnar styloid. So in this view, it's useful to assess your radial height and your radial inclination. Other views can be helpful in certain circumstances. If you really want to see the radiocarpal joint, what you'll do is you'll actually angle the beam kind of from distal to proximal, to match the volar tilt of the radius, and you can actually see straight down the radiocarpal joint. Or if you're, concerned about scaphoid fractures, you can, get a scaphoid view, which is, a little bit pronation, ulnar deviation, and a slight wrist extension to really get the profile of the scaphoid. On the lateral radiograph, the elbow is flexed 90 and adducted against the trunk. The wrist and forearm are in neutral position. The thing that makes a good lateral is the pisiform should be midway between the distal pole of the scaphoid and the capitate head. So, pisiform's here, so distal pole here, capitate there. So it should be, somewhere in that range there to really have a good lateral. On the lateral view, it's useful to assess volar tilt, which you can see here drawn nicely. It can also be helpful to get a tilted lateral. So basically you elevate the radius, 15 degrees to try and get directly down the lunate facet, and then you can elevate more to try and get directly down the scaphoid facet to really evaluate those fossas. And then one thing I've come across a few times is this teardrop angle. So on the lateral, kind of looking at what's called the teardrop, or it's basically that ulnar lunate facet, you bisect that directly and then cross it with the line perpendicular to the long axis of the radius. And that can help clue you into the quality of reduction, of that lunate facet, which is a very critical fragment in fractures. So down here is just depicted. A normal one is about 70 degrees. And in this case, it's 81. There's actually a fracture here. It's hard to see on this lateral, but there is a fracture in this view. Other radiographs which can be helpful. Obliques can help you evaluate the intermediate column, really to see that ulnar lunate facet or dorsal ulnar corner. One of my favorites is the extended tangential view, which you basically get, as is depicted here, wrist extended and then shooting down, basically looking at the distal radius sort of en face, and you can really see the sigmoid notch very well in that view. You can tell if there's screws there. You can also see the dorsal rim of the radius to evaluate your screw lengths as well. The other view that's useful for that is the dorsal skyline view, which you flex the wrist. This one's sometimes harder to get with the mini C-arm because you really have to get it kind of in that area, and it can be tough. So I like this view because you also get a nice view of the sigmoid notch here. But this is that dorsal skyline view, and you can see, screw lengths, making sure they're not too long, not going to rub on any tendons. So distal radius classification systems, many exist. They tend to be based on articular involvement, number of fragments, and presence of associated ulnar styloid fractures. So, you have the AO classification, which is more of a descriptive classification for like research purposes. The humerus is bone number 1, the radius is bone number 2, and then that's the first number, so 2. And then it's broken up into proximal, midshaft, or distal. So that's 1, 2, 3. So, distal radius would be 2, 3. And then A is extra-articular, B are partially articular with a simple split, and then C are complete articulars. And then those are broken down by, degree of involvement there. So, 2, 3, A1 is radius, distal, extra-articular and pretty minimal, whereas, 2, 3, C3 is, multi-fragmentary, comminuted at the joint line, many pieces to deal with. The Fernandez classification, which I didn't include on here, is basically breaking it down by mechanism. So you have, your bending fractures, your shearing fractures, they kind of classify them in that way. The fragment classification is depicted here, basically extra-articular, and then for the odds, it kind of describes the fracture, and then the evens, include the ulna. So extra-articular with the ulna is 2, DRUJ involvement with the ulna, is 6, and so on. The Malone classification, which is here, is depicted here. Typically, we don't use these as much as we do kind of the other classifications or eponyms of fractures, or purely descriptive is what we tend to use mostly. One thing I came across with Dr. Bravo was the radiocarpal dislocations classification and proposal for treatment. This is from Dumontier in France. It's a review of 27 cases, and it was kind of the largest cohort review of radiocarpal dislocations. They had 27 cases of it, and they basically classified them into 2 groups. They had group 1, which were purely radiocarpal dislocations with only a fracture at the tip of the radial styloid process. Mostly ligamentous plus minus a styloid process fracture. And then group 2 were radiocarpal dislocations with an associated fracture of the styloid process that involved more than a third the width of the scaphoid fossa. And we have a case that will kind of go through this and illustrate this a little bit better. But basically, their findings were that group 1 required reattachment of the ligaments through a volar approach to get good results. And then for group 2, you had to get an exact articular reduction through a dorsal approach as well to really get good results in terms of range of motion. And they broke down the range of motion that each group achieved and shared the results there. So going through some of the eponyms of the fractures, Colley's fracture is a fracture of the metaphysis with apex volar angulation and dorsal displacement, leading to this classic dinner fork deformity, as depicted here. This is obviously a child, but that's kind of the classic distal radius fracture you'll see. And then depicted down here, in picture and radiographs, sort of that dorsal angulation through the metaphysis. A Smith's fracture, typically these are a result of higher injury trauma on a volarly flexed wrist. They often have volar combination, but it's basically the opposite. So it's apex dorsal angulation with some volar translation, and you get this sort of apex dorsal here. And then you can see this kind of volar combination with this particular fracture pattern. Barton's fracture, they're broken down into volar type and dorsal type. So the volar type is the most common, or the more common of the two, and it's fracture dislocation of the volar rim of the radius. So you can see that here, in this picture, the dorsal cortex is essentially intact, and you have a fracture through sort of the volar rim with shortening. And the lunate tends to follow, whatever these fragments are doing. So it's important to recognize this fracture is not going to be treated well closed. That's one of the things that you kind of look out for. And then the dorsal type is basically the opposite, where it's, the volar distal radius is essentially intact, and then, dorsally is where all the fracture and comminution are, and the lunate and carpus will tend to follow that fragment over. Dive plunge fractures are depression fractures through the lunate fossa. Basically, it's a transverse load through the lunate fossa. You can see that here. The lunate is sort of shortened down relative to the scaphoid. You have a little disruption of Galula's lines there. And then you can see that fragment is sitting low. And this is a dive punch for anyone wondering, where does that come from? But basically a big heavy thing that presses through, a little hole. So basically that. The chauffeur's fracture, which are historically isolated fractures of the radial styloid process, also known as the Hutchinson's fracture, and they can be associated with ligamentous injury, particularly the radiocarpal dislocations, especially if it's sort of that transverse pattern through the radial styloid. And they're named chauffeur's fractures because, in the days of hand crank cars, when they would backfire when the chauffeur was trying to start them, it would force a load through the wrist and through the hand, and then cause this sort of fracture pattern. So that's where it comes from. The pediatric fractures, they have their own sort of varieties of distal radius fractures. So you have the torus fractures, which are sort of these buccal fractures here For those who don't know, it comes from Greek architecture. The columns in ancient Greece had, the fluting, and then the torus was sort of that flared sort of base, which does resemble, the fractures in those kids. The green stick fractures, which are fractures through, one cortice and then a bending moment through the other side. And then your physeal fractures, which are typically Salter-Harris 2s in these cases. So treatment guidelines, the LaFontaine criteria has been around for a while. 1989 is when his paper came out. And basically he identified 5 variables. And if you had 3 or more of these criteria met, it resulted in an increased likelihood of displacement of the fracture. His paper is very short. I think it's just over 2 pages with like 6 references. So it's worth a look. If you can find it, I have it for anyone who can't, and there's a reference at the end of the slides if you need to find it. But basically, the things he identified were dorsal angulation at presentation greater than 20 degrees, any dorsal comminution, any intra-articular radiocarpal fracture, an associated ulnar styli fracture, or age greater than 60. So if 3 or more were met, they had an increased likelihood of displacement. In their paper, they recommended close follow-up, to evaluate them. And then at this time, they had recommended possible repeat reductions. And, I think Vohra plates hadn't been around at that time. So it was other treatment modalities. The current AAOS guidelines, they recommend intervening on distal radius fractures when there's radial shortening more than 3 millimeters, dorsal tilt of more than 10 degrees, or intra-articular displacement or step-off of greater than 2 millimeters. So we'll go through some case-specific examples here. AL is our first patient. It's a 52-year-old female with right wrist pain after falling down the last step. On exam, her skin is intact. She's tender palpation volarly and dorsally at the distal radius. She has no obvious deformity, and she can make a full composite fist. So how about Neil? Can you read these ones for me?
Yeah. So AP and lateral of the wrist, right wrist. Looks like on the AP, can see a somewhat transverse fracture line with minimal to no displacement, kind of in the metaphyseal region. I think, let's see, also apparent on the lateral, but less so. I don't see any associated ulnar fracture. The carpus itself, at first glance, looks okay. So yeah, that's about what I see there.
Great. And how would you want to treat this?
I think this would be a good candidate for non-operative management. Probably a couple of weeks in a short arm cast, but I don't think that meets any of the criteria we discussed for needing operative intervention. So
great. So I agree. This is one I saw in my fellow clinic. She came in with these x-rays from urgent care, so I wanted to repeat a set just to make sure, we didn't lose anything in the interim. So this was my x-ray in clinic. You can see, she does have a degree or 2 of volar tilt still. She does have a little bit of dorsal comminution there, but otherwise, her inclination and height were still maintained. So I felt pretty good about this one being treated non-operatively. So this was a week later. I brought her back just to make sure, and it more or less stayed where it was. It may have settled a degree or 2, and she's now like neutral tilt. And this is at her final follow-up.
So I've got a quick question. When would you consider, in addition to an AP and a lateral view, getting oblique views? And I bring that up because, if I think, and maybe this is just me, a bias I have, if I'm going to treat these close initially, I think I need to get a really good AP lateral, and I do get obliques for my baseline. It's not that I get it every time, because I think it gives me an idea, and I think I've seen cases where I initially was going to try close, I got oblique views, and then the fracture pattern, and there were some things that made more likely to be this, and say, well, this is a lower energy mechanism, but just something I've added in my practice. If I'm going to get a baseline, and I'm going to treat them closed, at least I get a baseline oblique views, because I think that complements, and I can see the whole thing, because this is a 3-dimensional structure. And
Right.
and just because I've been burned in the past, just, food for thought. Probably our partners can mention they might not do that or so, but I think it's not unreasonable, and there's actually good data for it.
Yeah, no, I think that's a totally valid thing to get, and I did get obliques. I just didn't include them because I wanted to make larger photos here, but yeah, I got them, and I think it's important to get, particularly with any sort of articular involvement, because it can really tell you, if that dorsal or volar lunate facet piece is well reduced. I think you get a good view of that sometimes in the obliques.
And for Neil, if you were going to get this patient, you treat them close, you did well, but then they come back with some issues with the thumb, what would you be thinking for these type of patients?
Yeah, I'd be worried about like EPL rupture, potentially.
Yep, exactly. So that's what she's at risk for. In these closed distal radius fractures, I looked it up. It's about 0.07 to 0.88% risk of EPL rupture, usually on average of 4 to 8 weeks. And then I think their median number was 6.6 weeks after the fracture. So just inform them that, it's a possibility. There's not much we can do to prevent it as far as I know. But if it happens, we have things we can do about it. And I did have that talk with her as well.
And this is a question for my partners, because for a subset of these that I've treated closed, I've had them when they have this prodromal thumb pain. And one thing that, you can do under local is make a dorsal incision under local and unroof that EPL if you think it's a prodromal risk of EPL and they start presenting with significant thumb pain, and you can actually do that before actually ruptures. So that's why it's very good to advise them, because this is something that if you get them, there's a prodromal aspect that they'll present, and you can actually do it on the local in the office and unroof that EPL.
Sahil, there's one other complication that's more common with non-operative management. You know what it is?
Stiffness?
What?
Is it stiffness?
No. It's CRPS.
Oh, okay. Yeah.
Yeah. So, since you're on your sequelae slide, I think that's an appropriate thing to manage here.
Mm-hmm.
CAS disease, what it's been called in the past, but CRPS is more common in non-operatively treated distal radius fractures than operative ones.
Okay. Great. All right, our next patient is DK. He's a 56-year-old female with right wrist pain after falling forward when trying to pick up her new puppy. On exam, she has a closed injury. She's tendered palpation over the distal radius. She does have a dinner fork deformity, and she's neurovascularly intact distally. So how about Zach?
Sure. So it looks like another PA and lateral images of a right wrist has a dorsally displaced flexible or distal radius fracture that first glance appears extra-articular. There's also an associated ulnar styloid fracture I can see.
Got some dorsal comminution there too.
Dorsal comminution, yeah. Carpus looks like it went with the distal fragment. Yeah.
Good. So what do you want to do for this lady?
So in the ED, I'd like to get a reduction to try to improve her displacement and see if I can restore some volar tilt to her distal radius. That'd be my first plan.
And then what about long term? Do you think this one will stay, knowing the LaFontaine criteria?
She's 56. I mean, definitely concerned that it won't. There's some dorsal comminution, loss of your volar tilt. She's 56. So questionable what her
and then her shortening
her bone is.
More than 3
shortened. There's an ulnar styloid fracture associated with it, so certainly high risk for displacement. But I'd like to see what it looked like after a reduction.
Okay. So I'll tell you, it didn't look much better after reduction. So with her,
Okay.
ahead and went to open reduction internal fixation. Mainly for those reasons, we knew kind of based on history that it likely wouldn't stay where it was put.
Yep.
So this case was a learning one for me. I put my plate on quite distal, which obviously this fracture pattern did not need. Didn't quite need to be that distal. We can see it's still under the articular surface, but only just. And then, the plate's just past the watershed line there. I think, nicely restored the height and the inclination back, and our screws aren't in the DREJ. But that kind of leads me to this. The SUNG classification is another classification system we use, particularly applying to sort of plate placement for these Vohra locking plates. It's broken down into SUNG 0, 1, and 2. So 0 is where the plate is sort of dorsal to the watershed line. So your kind of FPL tendon comes right in close proximity to that. So basically, the plate's not rubbing on the tendon. SUNG 1 is where the plate is sort of just past, which is, I think, where I have it here. And then SUNG 2, where the rim of the plate is far beyond your watershed line there. So grade 2 are associated. Oh, go ahead, Dr. Bravo.
No, sorry to interrupt. So go back to your lateral on your fluoral view. So what would you classify that?
So I think we called this a SUNG 1.
Okay. So you're a little oblique, so it's actually probably a little 1, 0, 1. The thing is, you criticize yourself going distally, and I would correct. I think with these is when you really need to go distally. Look how much dorsal comminution you have.
Yeah.
Your only fixation, and that's what makes these Vohra locking plates, is actually to use that subchondral surface fixation which you have. And the mistake I've seen is that you go too proximal, you don't use your subchondral support dorsally, and then they collapse, or they actually don't get reduced, and you don't have that opening that you have there. That actually shows you that on that lateral that you've opened and got the length. So if they have got significant comminution, I mean, sometimes that's a mistake I've had even in some of my patients that I've been too proximal, and then they do collapse dorsally to some degree. So I don't know. I think for some of those, understanding that you really need your subchondral support for these because of the amount of dorsal comminution.
Right.
Yes. So
Cesar, this is Ted. I would agree with you. I think on this one, you pretty much had to be there. You in these, you get your fixation. This is one though where you want to have a high sense of planning to maybe go ahead and take the harbor out if they have any FPL irritation,
right,
or that type of thing. You might want to just go ahead and proactively talk to them about harbor removal. But I think that's where you have to be. If you go any more proximal, then that whole segment can tilt back.
Yeah, and the other thing is, if you look at that center hole screw, the locking screw there, I do put that locking screw. There's actually 2 biomechanical studies that look when they've got that metaphyseal diaphyseal comminution, just to put the locking screw, even if you get a unicortical, fixation because of the dorsal comminution, because the stresses with this plate, because it's a leaf plate, are pretty significant there. So if you've got a significant amount of comminution and there's any toggle, that's where that's going to fail. So I always feel that locking screw, because I've had it fail, and the few non-unions that I've had with this plate are the ones that didn't use that fixation. Just food for thought.
Good to know. Thanks, Dr. Bravo.
And the other teaching point is that when you start having a big zone of comminution, depending on the patient profile, definitely think about some type of graft filler or something to help your biology, because we kind of tend to be a little bit lax on some of these and assume they're all going to heal, but some extra biology is something to think about as well.
Thanks, Dr. Schuler. All right. So basically, yeah, like Dr. Schuler was mentioning, the grade 1 and 2s are at higher risk for plate removal, and grade 2 in particular, has a higher rate of flexor tendon ruptures, because you can imagine as the FPL comes over comes in close contact with the watershed line there, this plate is going to be rubbing on it pretty good.
And for you guys, so for the residents, when you guys are testing these patients and you're seeing them now, they're at 6 months, and you're wondering if they actually have any issues, examine them tell them to kind of hyperextend their wrist, because that increases the flexor tendon shear forces along the volar aspect of the radius. So if they start having significant pain, not only with motion, but with significant hyperextension of the wrist, that means that tendons are getting really irritated. So that may be a subtle way that they initially present with pain in that motion before they start having synovitis and swelling and complaining of deep aching pain. So that's one thing I do in my exam. When I see them at 6 months, I hyperextend them and then compare to the contralateral side, because that's when there may be some issues with the plate that can be elicited then.
Great, thanks, Dr. Bravo. All right. JD is a 27-year-old male with right wrist pain and hip pain following a motorcycle accident. He underwent a sliding hip screw replacement by the ortho trauma team for I think he had a basicervical femoral neck fracture. On exam of his wrist, he has a closed injury, he's painful range of motion, he's tender palpation over the wrist diffusely, and neurovascularly intact distally. So, Neil, would you mind taking a look at this one for us?
Yeah, sure. Again, standard views. It looks like AP, oblique, and lateral of the wrist, right wrist. Looks like a distal radius fracture. Does appear to be intra-articular on the oblique and the lateral. I can't tell if that's kind of like a little bit of a die punch there in the lunate fossa. There is an associated ulnar styloid fracture. Looks like some loss of the inclination, a little bit of dorsal inclination. Tough to tell without a contralateral about the radial height as compared to the ulna there. But yeah, that's what I see right there.
Okay, and sometimes these ones are tough to tell. So in this case, I think they got a CT scan after their reduction, and you can kind of a little more clearly see that. This is a little bit more of like that dorsal Barton kind of pattern, where the dorsal rim of the radius is what's comminuted off, and the volar rim is more or less intact. You can see there's maybe a tiny non-displaced split through here, but most of the action is back here dorsally. So treatment options for him. What do you think, Neil?
Yeah, so I think he would be indicated for surgery. As far as plate options, I'm not sure that going a standard volar approach would allow you to address the fracture fragments like you talked about, primarily being dorsal. So I think you'd need some dorsal hardware, maybe a bridge plate, depending on how comminuted those fracture fragments are. It looked pretty small as well on the x-rays. It was tough to tell.
Yeah, I think those are good thoughts. So that's kind of what we did in this case. We had planned initially to go dorsal and do all of our work dorsally, because that's where sort of all the comminution and fracture was. So first, in this case, I think we applied our dorsal plate here and really kind of booked open the fracture, and then there was that free fragment kind of centrally that we elevated up with the freer and then sort of held in place once we booked it open. And then I think we had placed this screw first to really kind of compress the plate in and just hold everything. We didn't really need these more distal screws because the force of the plate was actually holding that reduction there. And then for that sort of transverse radial styloid component, we added this radial column plate to help prevent that from shearing.
Sahil, that looks beautiful. So one question: when you went dorsally for this, was the carpus dislocated, and did you have any stability in the DRJ? And my second question is, when you place that radial column plate, did you guys put it between the first and second compartment, or just within deep into the first compartment? Because I've had some difficulty with this plate, and I just want to get you guys' opinion on that.
So his carpus was dislocated dorsally. I remember Dr. Apel pulled traction and we sort of tamped up the joint surface, and then kind of got our plate provisionally on, and that sort of held it. He didn't have any DRUJ instability. And then I think we had put this one in the floor of the first compartment directly. Correct me if I'm wrong, Dr. Apel. I think we released the entire first compartment on this one and put the plate right on the floor of it.
I don't remember if this one, I know we did 2 of them in like a week. I can't remember if this is the one that we did where it went on the dorsal radial face or if it went truly on the radial side. I just don't recall. That sure looks like it's in the floor of the first compartment, though.
Yeah.
Yeah, and I asked because that's one thing with this radial column plate from Synthes. I think the way they designed it was within that septum between the first and second. You can still put it on the first because usually that's where we need to put it. But if it's very comminuted, I mean, you guys got a perfect length. Sometimes you can hyperextend that radial styloid on the lateral. So it tends to hyperextend. And if you put it only on the first compartment, you've got significant comminution. That's just for something to be mindful because you might need to contour the plate so you don't hyperextend that radial column. And it's kind of subtle because it tends to be straight and our radial column is not straight. So that's something to think about. And the other thing is when you see these patterns, the dorsal, there's actually a new classification for these based on CTs that came out in 2020. They are dislocations until proven otherwise, and you'll have either a lip on the dorsal radius, you'll either have central impaction, and you may also have an articular portion on the volar portion, like in the lunate margin. That's why the CT that you guys got is very helpful, not hurtful, because it'll kind of guide you in your treatment. Because if you guys would have seen that, you would have, on any volar aspect, you would address it volarly and not being surprised. So,
yeah, it's a good point. And then our final one, BH. He's a 24-year-old male with right wrist injury after a fall while playing flag football with immediate deformity. A closed reduction was performed in an outside facility with overall good alignment. He underwent a trial of closed treatment for a brief period. On exam, he had moderate tenderness around the distal radius with some guarding on exam. He had edema as expected. His skin was intact and he was otherwise nervously intact. So Zach, I'll have you help me out with this one.
All right. So it looks like, again, right wrist with fractured distal radius with shortening and it's like dorsal dislocation of the carpus relative to the radius, associated ulnar styloid fracture.
Mm-hmm. So what would you want to do with this one?
It's a very distal fracture. I think, again, get it reduced, see kind of what sort of, like if there's a fragment dorsally that can be tamped up and kind of help to hold your reduction.
So this is
that
post-reduction
styloid piece as well. Okay.
So I agree. This one's tough. It's very, very distal. Overall, the alignment looks fair. You can see the carpus is now sitting back on the distal radius here. You can see that big styloid fragment, but it's got a little step off, but nothing terrible. So to further evaluate that, we ended up getting a CT scan, which demonstrated this. So even though it was a dorsal dislocation, he was now kind of subluxing volarly, along with just that tiny little volar fragment there. And we can see kind of the step off of that styloid fragment there as well. And then that dorsal rim fragment was also very small. And then this is kind of the axial cut where you can see that volar piece and then the dorsal sort of rim as it's coming off. So in this case, this is where we looked at.
Can I make a comment real quick?
Yes.
So you got to resist the urge to just throw a dorsal plate on this, a dorsal bridge plate. This is a globally unstable radiocarpal dislocation, and they're extremely powerful devices, and they can pull you dislocated off the other direction really quite easily. So I don't know if this was my case or not, but the inclinations be like, oh, I'm just going to put a bridge plate on this. But that can actually be a very challenging case because of the global instability.
Right. That's a really good point, Dr. Apel. This is where, Dr. Bravo and I had kind of talked about that Demontier paper on the radiocarpal dislocations. And this, would be a grade 2 because this is more than a third of the scaphoid fossa length there. So knowing that, we went both volarly and dorsally. So we started volar, and we first put down, a row of anchors along the watershed line to, later tack back down the volar capsule of the wrist. And then what we did was, put some, I think these were it was a 3-5 wire and a 4-5 wire, if I'm not mistaken. We put those down in that small little fragment we had here to capture that. And then we used this kind of spring plate technique where we then placed them down, bent them, and then put the plate over the top of it to hold it. We repaired the capsule back to the watershed line there where it had avulsed off. And then we pinned the styloid fragment into place, and then eventually ended up swapping it out for a screw. And then after we did all that volarly, then we went dorsally and put our dorsal plates along with another row of anchors to help attach back the dorsal capsule. And this was our final construct. And then we ended up putting an X-fix on just to maintain him, because we were worried about that sort of carpal shift. We wanted to just let the capsule heal in before we really had any strain on it. Dr. Bravo, I think you've seen him back subsequently by now.
Yeah, I did just remove his X-fix. And you may think, I'm crazy putting an X-fix after we've done all this. It's just these are very unstable, and he was somewhat delayed already, so he was already scarred down volarly. So even after we went in, he had completely avulsed his radiolunate, his radioscapitate on the volar aspect. Then on the dorsal, he also had a dorsal shear. Now looking back, this had a component not only of a radiocarpal dislocation, which we saw there dorsally, but also had that dorsal Barton shear component to it.
Mm-hmm.
So it's that globally unstable. And what's difficult with these is that they usually present in delayed fashion. And if they're missed, it's a problem, because then this is an arthritic machine to happen. And if this doesn't, he's going to be somewhat stiff, but if we get them early enough, they actually do well. But when they're missed, they do very poorly. And that's a very difficult problem to treat in the long run. So that's why understanding the pattern and going after them, and then addressing the ligamentous support, and then your boning structures. And because it was so distal and so small, that's why we did that spring technique, because we didn't think we could actually get it as well with the hook plate or separate screw, because it was fairly comminuted.
Mm-hmm. Yeah, I like that technique. That was my first time doing it, and it turned out nicely.
It's Chan. This would have been a great case for the volar rim plate. I mean, it's basically made for this kind of fracture. I mean, I think it would have really set nicely with that, and you wouldn't have to use the K wire to add that extra. But and was it unstable after you fixed it? Was that why you did the X fix, or just as a precaution?
We put the X fix because it was already settled volarly, so it was already contracted, and he's fairly young. So for those, even if we get good fixation, they tend to want to kind of contract back. So I take that factor out, and that's why I put the X fix. And we did have an owner column plate from the TriMed. We ordered that before, so I mean, I kind of super planned for this. And the thing is, it would not lay as we wanted, because he has this type 2 kind of volar marginal segment of the lunate facet, which is very pointy. So his plate would not fit. And we actually ordered it specifically for this case. We had like 3 trays. So, but yeah, that's a good point. I mean, we thought we were going to be able to only get an intermediate column and then anchor across and repair the soft tissues. So if you let me share the screen, sure. I can, and by the way, excellent job. Thank you. That was awesome. Can you guys see my screen?
Yep.
So this is something I just want to bring up because, I mean, as he talked about the different classifications, just like Sahil mentioned, the Moncure is basically radiocarpal, which is just pure ligamentous, and that's what he based it. And those are the ones that tend to go on the basically in the owner shift, that they don't have much fragments, and they can be either dorsal or volar. When they're type 2, that's when you've got that fragment. But one of the things that you guys need to, that I've understand over the years, and with these new type of Barton kind of dorsal shear and fragments that are associated with urocarpal dislocation. This is a great study if you guys have time to look over it. It's actually from the European Journal of Hand Surgery, and basically broke these dorsal shearing segments into these where you have a purely ligamentous, and then you kind of progress to more of a bigger segment. But the biggest thing is when you see these fragments on the dorsal segment, they usually are flexed, and that's kind of telling you, man, this is not just a simple dorsal distal radius fracture. And then that's where the CT comes into mind, because once you go from a type 3B to a type 2B to a type 3, you're going to start having segments on the volar shear segment, which is what this patient had. So you need to address that volarly and dorsally. So this is just something to think about when you see these radiocarpal dislocation, that sometimes they're not only just issues with the basically the radial column going orally, but also volar and dorsally with the shear segments. Hopefully that's helpful. I can stop sharing.
That's great. Well, thanks everyone.
It's awesome.
That's all I have for you.
Thank you, everyone.
Thanks, Sahil. Great job.
Thank you.
Sorry, great job. I recorded it, so we have it.